Hello, everybody, again. Welcome to iCubed. This is Dr. Alice Lee. Welcome to iCubed episode 27. Yeah, this is my third year doing this, and it's been a wonderful labor of love. I have invited a repeat guest to join us today. We had her last year, and she was wonderful on the screencast. Why don't you introduce yourself?
Hi, Alice. I'm Dr. Elisa Dannemiller. I did my residency at Denver Health in Colorado.
Yay!
And I currently still live in Denver, but I work for Team Health West and work at several different sites in the Western region, including Colorado and here in Arizona.
Yeah, we love having you here in the winter to help us out. You've been great, really a great partner through these very difficult months.
Yes, the snowbird season is quite busy here, but the weather is fantastic.
Yes. You just played tennis this morning, right?
I did,
Yeah.
But I'm missing all the powder in Colorado right now.
Well, did you try skiing up north? Because we had a lot of snow this year.
You did have a lot of snow.
Yeah.
In fact, I was in Revelstoke, British Columbia, and you had more snow in Flagstaff, Arizona than we had when I was in British Columbia.
That reminds me, Arizona, like in March, is the only state where you can have all 4 seasons in one day. All right, so I've got 2 patients I want to present to you, and let's just talk through them and figure out what to do, what they may be, differentials, and what kind of testing to run. So the first one, so she's a 60-year-old, very healthy female. She's brought in by her old friend of 34 years, and they actually live together, right? Her friend says she can't remember anything. That's the chief complaint. The friend says they were getting ready for a walk about 6 hours prior to arrival to the emergency department when the patient completely forgot their conversation. The friend reports that the patient's forgotten everything that's happened since then. I'm looking at the patient. She's, sitting there and she's very calm. The patient says she has some blurry vision and tingling in her left thumb and her ring finger. She denies any other physical complaints. She knows her name, she knows her birth date, she recognizes her friend at the bedside, but she doesn't know how she got to the ER. Okay?
Okay.
There's been no recent falls, no trauma, there's been no major life changes. Past medical history is negative. Surgical history, C-section, tonsillectomy. She's never smoked. She drinks occasionally, but hasn't had any for 2 days. And she denies any drug usage. Her vital signs, blood pressure is 150/82, her heart rate is 72, respirations are 13, somebody counted those breaths. Room air sats are 99%, and her temp is 97.9. General examination, completely normal. Non-focal, except for the orientation questions. She knows her name, she knows her friend, and she knows that she's in a hospital. Okay? So that's your first few minutes with your patient. Anything you want to ask? Anything more? Any more exam or history?
Her memory loss, is it just short term? It sounds like she remembers long term.
Right. So she doesn't remember anything, this friend says, from today.
And did she wake up like this? When does her friend last remember?
Her friend remembered her being normal when they got up. But then when they were getting ready to go on their walk, they were talking, and the friend noticed that we just were talking about something, and you completely forgot about that conversation that we just had.
It's odd. It makes me think of like transient global amnesia.
So that's one differential. What else?
She's 60 for Baywood. That's quite young. But you could think of an infectious etiology.
Okay,
like, does she just have an underlying, UTI that's making her a little bit forgetful? I had a patient like that the other day who called her daughter 3 times to tell her to come pick her up in 10 minutes. So I would certainly think about, a mild infectious etiology as well.
Right. So like a meningitis type or encephalitis.
Encephalitis, a UTI.
Mm-hmm. Oh, I see.
That kind of...
a more broad kind of differential. Right.
But it definitely sounds, more CNS neurological to me.
Right.
Based on her vital signs, it doesn't really look like you would be concerned from an infection just from her initial appearance.
Right. What do you think we should do at this point? I mean, you examined her, you've got, your history, the most you can get, as much as you can get pretty much.
And I would do a more detailed neurological exam in terms of coordination, does she have a pronator drift, any dysmetria, So she was complaining of the blurry vision. So I'm thinking more, does she have any other associated focal findings?
Right.
Kind of on a more detailed neurological exam, and maybe also look at her gait.
Mm-hmm. No, she ambulated fine. No ataxia. She had a non-focal examination. She had a complaint that was the thumb and the pinky, ring finger. But she had no drift. She had a very, very non-focal examination. No dysmetria and no nystagmus.
So I would start by getting some labs. I would check a CBC and a comprehensive metabolic panel, and I would do a CT of her head.
Yep. All right, let's put that on hold. Let's see and meet patient number 2.
Orders in process?
Yes. This might be a more interesting case. So the patient number 2, I saw these 2 patients in a span of 9 months, interestingly. Anyway, so he's a 68-year-old guy. He has a history of prostate cancer. He's brought in by his wife for evaluation of his acute confusion, which started about 3 hours before coming to the emergency department. Wife says patient just had a total prostatectomy recently for cancer. And then this morning, he used for the very first time a prescription injectable medication for erectile dysfunction. She says that he was normal about 4 hours prior to arrival when he went into the bathroom to inject himself. So after their private, intimate time together, he was immediately confused and could not remember anything from today. And the wife says he keeps asking the same question over and over again. Now, I look at the gentleman. He's very calm, talking to me. He says he remembers he was helping out at the food bank yesterday, and he doesn't remember what he did today. There's been no recent falls or trauma. And then other than the total prostatectomy for cancer, he had no other major life changes recently. So we look at his past medical history: prostate cancer, osteoarthritis, sleep apnea, surgical history. He's had that recent radical prostatectomy. He's had a wrist fracture, surgery, and vasectomy. Social history: he's never smoked. He occasionally drinks beers, and he denies any drug usage or drug abuse. And then looking at his vital signs, blood pressure is 167/70, the heart rate is 64, and respiration is 18, room air stats 96, temp is 98.2. Pretty normal. General exam, completely normal and non-focal, except for those orientation questions. Sounds like the first one, huh?
Yeah, it does.
So a little more detail on neural exam. So like I said, he's had a non-focal exam. He knows his name. He recognizes his wife. He's oriented to the correct year. He deduced that it was Saturday because he knows that he went to the food bank on Friday. So same thing here. That's your first few minutes. Anything else that you want to ask or do?
It looks like he was a little bit hypertensive.
Slightly.
So I was thinking that maybe with the medication, if it were a Viagra or similar type of medication, maybe that would have dropped his blood pressure.
Right.
And he had maybe an event associated with hypoperfusion.
Right.
But now he's a little bit hypertensive. So does he have no complaint of pain anywhere?
Nope. He had no pain. He had no focal complaints. He had no focal findings. He looked very comfortable just sitting there. And his wife was providing almost all the history.
Right.
But he was conversant and no headache.
Without wanting to ask too many personal questions, just make some assumptions, and I would consider a spontaneous subarachnoid hemorrhage because he had perhaps exerted himself, and his blood pressure could have elevated and put himself at risk for a subarachnoid hemorrhage. For
sure. That's definitely a very valid differential. So I did investigate, or I did ask them what prescription medicine. It's something called Trimix, and it's prescription injected into the base of the penis, and it has 3 ingredients.
Okay, so I wouldn't expect that to decrease his blood pressure systemically.
Correct. So you've got your 2 patients, and we've met them, and now I'll tell you what I did. My ED workup was very similar to your thoughts. So the first one, which is the 60-year-old lady, I did their CBC, CMP, aspirin, Tylenol, alcohol levels. I do a lot of tox screening, just depending on my suspicion on the patient. I did a chest film, EKG, CT brain. For patient number 2, that 68-year-old gentleman, I did similarly CBC, CMP, coags. I'm not sure why I ordered coags on him. Chest X-ray, EKG, and the CT brain, like you had suggested.
Well, I think the coags make sense because if you were thinking of a subarachnoid hemorrhage, the first question your neurosurgeon is going to ask is, what is the INR?
Right. Right, and then sometimes these seniors don't really know their meds. They may think they're not on a med, or they forget or something, so.
Yes, I think all the anticoagulants sound like Star Trek characters.
Right, that's funny.
I can't even remember them all.
So anyway, the workup for both these patients were unremarkable, and CT brains were negative. Yeah. Now what? What do you want to do? Do you want to admit them? Do you want to send them home? You're just confused, sorry, come back. Or we can refer you to an outpatient neurologist or something. What would you do? I mean, in fact, what would you do here versus back at home, if anything different at all?
Right. I think I would phone a friend and call our friendly neighborhood neurologist. We do have some here at Baywood who are actually very helpful.
Yes.
Other facilities, neurology is a difficult consult to obtain simply because there may not be any neurology on call because there are no neurologists in the area.
I see.
But sometimes you'll have the telestroke camera that will also do a non-emergent neurology consult.
Interesting.
So sometimes that may take 5 hours because the strokes are prioritized, but you can still get a detailed neurology consult with the telestroke. So
have you worked in a place that has that?
Yes, many places have that. Mm-hmm. Yeah.
So that's great. Well, here I called our neurologist, and in fact, the same neurologist for both of these patients that happen to be on call, and that neurologist is known to be quite conservative and test everything. So we went ahead and admitted both of these for a stroke workup, basically. Which is
interesting because you don't think of stroke presenting with altered mental status.
Yeah, they're not altered mental.
Altered, it's more memory loss.
More amnesia, exactly. So,
and I think that distinction is very important to make. Because I could see how the family could say they're confused, they're altered, but really they just had a period of memory loss.
That's right.
Because I can see myself making that very same mistake.
Right, so. Exactly, yeah. My screencast has 2 learning focuses. I try to kind of teach and narrow our learning to 2 points, hopefully, so that we're not scattered all over the place. I mean, each one will be just teaching a main teaching point related directly to the particular patient scenario. Like last time when you and I talked, I was talking about intubating, those flash burns. Remember, we were talking about intubating. So I wanted to address flash burns specifically. Right. So, and can you guess what his first one is? Our first learning focus is...
transient global amnesia.
This first learning focus is the diagnosis, basically, of transient global amnesia. Both of those patients were diagnosed with TGA by the neurologist, confirmed by the neurologist. So these are 2 great review articles. And so transient global amnesia is kind of a fascinating entity. It's a clinical syndrome that's characterized by a sudden onset of anterograde amnesia. There's repetitive questioning. There's sometimes some retrograde amnesia. It can last up to 24 hours, usually 4 to 6 hours. And there is no compromise of any other neurologic function.
So her numbness in her 2 fingers that didn't correlate to a nerve distribution was completely a red herring.
Correct. I think that's what it was. Yeah, exactly. So before we go on, just a quick, really brief sort of going over basic memory concepts. So there are 3 types of memory. There's immediate memory, which you can test by just having someone repeat 7 numbers. It's just that quick working memory that you're dealing with, right? And then the short-term memory is where you can lay down some new information, and then you keep it in your brain. And you can recall events of the day, for instance. That's short-term memory. Long-term memory is remote memory, such as where you were born, what schools you went to, okay? So transient global amnesia is a temporary interruption of short-term memory. And affecting the hippocampus will produce anterograde amnesia. So transient global amnesia was first described in 1956 by 3 doctors, actually simultaneously. TGA is a clinical diagnosis. Pathophysiology is still quite unclear, even though there's a lot of literature out there about it, a lot of studies. It is typically found in patients between 50 to 80 years old. The peak age of TGA is 62. There's slightly more prevalence of females versus males. The annual incidence is 3.4 patients to 10.4 patients per 100,000 people. The annual recurrence is really, really low. There's different estimates, but it's really, really quite low. It is more common in patients with migraines. The TGA patients actually have more hyperlipidemia and ischemic heart disease, and TGA patients have significantly higher percentage of psychiatric illnesses. The most frequently cited precipitating events are emotional stress immediately prior to the episode, not like 2 weeks ago, just immediately prior to the episode, physical effort or exertion. And then what I found was a little bit odd is the third most frequently cited precipitating event is water contact or temperature change. Like if you dove into water, cold water. There's been cases cited of that as being a frequent precipitating event for people. There are 4 main hypothetical pathophysiology mechanisms: venous insufficiency, arterial ischemia in the brain, migrainous phenomenon, or epileptic phenomenon. So then the clinical presentation, they're often brought in by somebody else because they're patients with TGA aren't really aware they're having that problem. So for instance, both of my patients, one was by the wife, one was by the girlfriend, a lifelong girlfriend who knows her well, right? There may be mild vegetative symptoms such as headache or dizziness, nausea. That one woman has some blurriness, all right, just sort of vague blurriness. They sometimes can be very anxious or nervous or confused. Like they don't know what's going on and they keep asking the same question. So they can get a little anxious just because they realize they're lost, sort of, And then in terms of their overall examination, they have preserved speech, motor function, coordination, alertness, self-orientation, and they recognize their family and friends. It only lasts typically a few hours, often 4 to 6, and definitely less than 24 hours. Okay. The amnestic gap, there's an amnestic gap for the duration of the episode. So during the episode, they don't lay down any memory, so they have no idea. Like both of my patients didn't remember what happened that day.
I wish you could choose to have this selectively.
All right, right, exactly. So then TGA, there's diagnostic criteria. One of these articles has some nice graphs. So just going through it so that we really understand and how to make the diagnosis. These attacks must be witnessed and information available from a capable observer who is present for most of the attack. There is clear-cut anterograde amnesia during the attack, so they just can't lay down memory, new information. The cognitive impairment is limited to just the amnesia. There's no clouding of consciousness or loss of personal identity, okay? So they know who they are. There's no accompanying focal neurologic symptoms during the attack and no significant neurologic signs afterwards. There's an absence of epileptic features, and there's resolution of the attack within 24 hours. 24 hours, I've said that a few times. And then patients with a recent head injury or active epilepsy are excluded from this diagnosis. I like this quote. It's a TGA rule-in criteria that makes things a little bit simpler. So this is from Dr. David Spiegel et al. In Transient Global Amnesia, Current Perspectives in Neuropsychiatric Disease and Treatment, October of 2017. So this is the TGA rule-in criteria. Anterograde amnesia in a clear sensorium and cognitive impairment limited amnesia is the main rule-in criteria for TGA. Additionally, the amnesia must last less than 24 hours. I think that's simple. You kind of touched a little bit on the differential diagnosis, and there's a lot of them actually, more than this chart shows, but I just want to focus on 2 of them. Have you ever heard of this one? Transient epileptic amnesia?
I have not. No.
Then me neither. That's why I like doing these. I learn all sorts of things when I do these screencasts. So the transient epileptic amnesia differs in that the duration is less than 60 minutes and it's recurrent. These episodes recur. And very frequently, these patients will have oral automatisms, olfactory or gustatory hallucinations. So they probably smell something that's not there, or maybe they taste something that's not there. And then they have abnormal EEGs. Versus transient ischemic attacks, TIAs, we're all very familiar with these, right? So the duration of these attacks vary from minutes to even permanent damage sometimes. These patients, the TIA patients, have associated neurologic symptoms, right? And then they've got a normal EEG. So a workup for TGA, well,
doesn't sound like there's a whole lot to do once you make the diagnosis.
Right, exactly. Except to rule out other things. Right.
And engage your neurologist.
Yeah, exactly. So main value of testing is to exclude alternative diagnoses. So here's a diagnostic algorithm that is very, very clear, actually, and very simple. So if you have a patient come in with sudden onset of anterograde amnesia, you first have to see if there's any associated neurologic or other symptoms, right? So going on down the left arm, no. Like our patients that had no neurologic symptoms. And so from there, on that arm of the algorithm, you find out how long is the duration of these episodes. If it's hours, then we're talking TGA. If it's short minutes or recurrent, we're talking TEA, right? And then if they do have neurologic symptoms, that goes down the right arm of the algorithm, then at that point, we're going to consider other neurologic diseases, and further studies are definitely warranted and must be done. Treatment of TGA? What do you think?
Doesn't sound like there's anything to do.
There's no specific treatment. There's nothing to do. You're right. You're absolutely right. Learning focus number 2. I'm just going to show you. Sex, then amnesia. This is a little bit of...
I would not have guessed that one.
Yeah, this is kind of fun. So this was the injection that second gentleman had used. It's called Trimix. And it's a prescription medicine with 3 ingredients, and it's injected in the base of the penis just prior to sexual intercourse. So I thought at first that was the problem. I thought it was a drug reaction. I thought maybe, okay, he became hypotensive, or he had vasospastic, episode, and he had a stroke or a TIA, right? And that's why he had that loss of memory. But no, it wasn't a drug. I was blaming it on the drug, but it wasn't a drug. It just
happens.
It's just transient global amnesia. There you go. Sex, then amnesia. And so this article talks about a patient a female who, after she had sex with her husband, she had no memory of that. Another article from Fox News. But there was an article I found. This is a case report from Croatia. One case was a woman who had sexual intercourse and she forgot. She had no memory of the preceding events after having sexual intercourse. And the second case that they reported was a male, same kind of thing, where he had sexual intercourse and he had forgotten. And both of these were in their 50s or 60s. So it's very much
I know roofies are involved.
I don't think so. All right, so they each had a CT angiogram of the brain and an MR of the brain without contrast, both negative. Interestingly, though, in the hospital, they both had lipid panels done, and they were both slightly high, and that was one of the characteristics of the TGA patient that is noted, Hospital course for patient number 1, the neurologist note 2 days later says, she's awake, alert, and oriented times 4. She registered and correctly recalled 3 objects. She had no difficulty doing serial 7s. The neuro exam was normal. The EEG was normal. Hospital course patient number 2. The next day, the neurologist said, I warned the patient to avoid injections as well as Cialis and Viagra for erectile dysfunction in view of potential increased risk for strokes and TIA. Have you had a patient with TGA ever?
No, I have not.
Oh,
At least
really?
not that I'm aware of.
Oh.
Well, not that was associated. I mean, I've had several, but there was a clear head injury or car accident or some sort of.
You've had amnestic patients, but then they were not TGAs.
Right, they were not TGAs, unless I've missed it and haven't realized it. Because I think sometimes families are brought here and people say they're confused or they're altered.
Right.
And they seem fine when you evaluate them. But I think it's an important question to ask the family is, what do you mean by confused?
Right, exactly.
Are you just asking the same question? Do they have a memory loss? Or are they actually just confused?
Right,
and that's an important distinction to make. It's possible that I've missed it. Although, having ruled out the other bad things in the emergency department, I don't think it caused any harm.
Right.
It's certainly interesting.
It's interesting to me that you thought of that TGA as a differential, because I had never heard of it until I had a patient 20 years ago when I was like lost. Well, what was going on? And I called the neurologist, and the neurologist told me, "Oh, that sounds like transient global amnesia." And I remember distinctly going, What is that? I'd never heard of it. And I think it was an elderly gentleman had driven himself across the state, the other side of Arizona, and wound up in our hospital in the ER. And I was just floored because he didn't know how he got there. He was fine and neurologically intact. So when I called the neurologist with this, the neurologist recognized it right away.
Right. Well, there's a movie called Memento where the character had TGA.
Is that
right? Or now knowing the difference between the criteria between TEA and TGA, if I remember correctly, this character would continually forget things and bursts. And so it was more of like the epileptic version. And he would leave himself sticky notes everywhere to recreate the memories that he wasn't able to produce. So
that was a great movie. I remember that movie. I think I'm gonna have to rewatch the movie.
And it's been years.
And he wrote it.
I watched it as a kid.
He wrote it like he wrote notes on his hand or on his
and then he started writing everything on his body. I'm remembering more as we talk about it, but then his whole body was covered in notes and yes.
Oh, interesting.
I just need to look that one up.
I need to look that up. That's interesting. So this entity has been known for like 60 plus years now, and they still don't know exactly what causes it. But I thought it was just a very interesting disease to talk about, and it's really. You'll look like a star when you make the diagnosis, and you can pretty much make a diagnosis just clinically and with a detailed history and examination. You don't really even have to do a lot of radiologic studies. So I hope you learned something with us.
I did.
You
Thank
did?
you.
Well,
yes.
Thank you so much for joining me again. You were great last year, and I'm so glad we were able to do it this year as well. And thanks everybody for watching. I hope you guys also learned something today with this screencast. Once again, if you see me at a conference, don't hesitate to come up to me, okay? I would love to hear your reactions and your input and any suggestions for making my screencast better. So, thank you, everybody. See you next month.
Thank you.
Bye.